Hi, it's Jenny B, NSWOC. So I'm back still with our series on diabetic foot ulcers, and today I want to talk about one of those factors that can really affect the healing of a DFU, which is called vasculopathy. Vasculopathy is just the fancy word for saying the diseases of the vascular system. So why is it so important to actually determine the vascularity of a limb? Well, I'm going to tell you, it's one fairly simple thing. It's oxygen, because man, we all need that oxygen. If we don't have it, the tissue can cause tissue death. And or something called hypoxia. So that's where the tissues are actually starved of it, and then slowly can deteriorate. Sometimes it happens quick. Anyhow, we're going to talk about, so arteries, they take the blood down the limbs and towards the furthest away from the heart, and the veins take them up. Why is this such important? Why is it so important? So again, the large arteries, they do that, but then there's a lot of branches off them called capillaries. And those capillaries, they do this meshing thing where they exchange oxygen for carbon dioxide. So this is where the oxygen is then fed into the tissues. And if they're not able to do this exchange, then that's when some of the badder things can happen. Again, such as tissue necrosis. So if some of these little capillaries even can build some little plaques, sometimes it can actually be in the large arteries. That's why we end up with a lot of amputations and whatnot, and it's usually due to the fact that it can't get blood flow down. So two factors, such as one being smoking and the other being diabetes, especially long-term and uncontrolled, can have effects on something called atherosclerosis. That's hardening of the arteries or plaques that build up in the arteries itself. So why is that so important? Well, if these clog up, they're not able to get oxygen and do this oxygen exchange amongst your arteries to your veins, and therefore it creates, again, hypoxia or decreased oxygen to the tissues. So again, when you have a diabetic foot and they also are neuropathic and they can't feel, sometimes they're not even aware that some of these things are happening. So the reason this becomes important is because sometimes there's in the capillaries, there's blockages in the small vessels, but when there's blockages in the larger vessels, this is actually when we can optimize, or there's some surgical procedures that can be actually performed to help, so we can increase the blood flow to the limbs. One of the big ones is something called the superficial femoral artery. That they can do something that would a procedure that would actually try to bypass that. This will actually, sometimes it's done actually even a little bit lower than the popliteal artery, so that it actually can get better flow. If there is flow issues behind the knee, it's actually very difficult for them to revascularize, and anything in the lower limb, because the arteries narrow too much, they're not usually able to have any interventions completed. So the big ones are the SFA and then the common femoral artery, those ones, and then if there's anything with the internal iliacs, those are definitely ones that we want to explore. So often I'm requesting the use of a CTA to be completed, and this can help determine whether or not there can be some intervention done and completed. When there is a lot of issues with the smaller vessels, it's not always as ideal to try to treat. So how do we know that this is happening? Well, often when I see these lovely circular eschars, areas of necrosis on the base of the feet, sometimes I'm actually looking to see, what is the cause of this? Is it actually just pressure, or is there an actual vascular element? Also, because of the lateral aspect of this, it often is the tibial arteries that are impeded, and that's why we're getting necrosis within the actual wound. So one of the easiest ways to check for this is waveforms. So there's three types of sounds that you will actually hear when you check via Doppler onto the foot. I did the echo program with Gary Sibold over the winter time, and he's actually now saying that the ABIs, not that they're not fully relevant anymore, but they're unreliable. So we're actually not really completing them as much as we are actually relying heavily on the type of waveforms that we're hearing. So I'm not going to go through all the different ones in this video because there's lots on YouTube that you can hear the difference, where it's monophasic being 1 sound, biphasic being 2 sounds, and triphasic being 3 sounds. I will place a link of different videos that you can look at waveforms in there as well. This is a very quick way and kind of a way I've always done to check for vascularity, whether or not they're actually going to need some testing completed. So some of the other problems is that, again, not all patients are able to have a CTA completed or a CT angio. Those patients with an EGFR under 30, for the most part, their kidney function is already poor enough that they wouldn't be able to have the contrast dye to have that completed. Those patients are often then to be seen, every 6 months or to a year in a vascular clinic, where they can complete something called an arterial duplex Doppler. This is an ultrasound type of test that they can do that can be just as effective, but then will give clues to when they potentially may need a CTA or if surgical intervention is required. Okay, so again, monophasic sounds, those are always when there's only that 1 sound that there's concerned. So what can they do to unblock these arteries? Well, if you're seeing that there's occlusive disease on the CTA in, again, the superior femoral artery or superficial femoral artery or the common femoral artery, those are times that we do need to then refer the patient on to a vascular surgeon. One of the most common things they can do is actually something called an angioplasty. This is where they actually put a wire into the groin and it runs down into the artery, and then they inflate a balloon, which then helps to break up those plaques and that can unclog it. Again, this is something that's determined by a vascular surgeon if that procedure is what's appropriate. Again, if they're able to actually get the balloon down, or if they would require something called a femoral popliteal bypass. So that graft itself is basically what they'll end up doing, and then they attach it right into the popliteal artery, and they will either take a vein from their lower leg and flip it upside down to make it an artery, or they will actually use a plastic tube or a graft of some sort to try to bypass. So it really depends on the status of the patient's veins. Again, the bifemoral grafts are usually actual tubes that they would actually bypass if especially they had bilateral femoral artery blockages. So there are other procedures that can be done, but this is one of the things that we do want to try to complete to optimize a diabetic foot ulcer if there is any signs of peripheral vascular disease. When it is in the small vessels, it's much more difficult to actually treat. Oh, and again, hopefully that helps with understanding of the vascular system and how this can be affected to a diabetic foot ulcer, and when we should be pushing further for testing, and when again we can have a look and see and check on ourselves just with our Doppler and be able to determine the vascularity of the limb on our own and when we're going to have to reach out for help. Thanks again for watching, and remember, the best wound is a closed one.